Good morning and welcome. Welcome to today's workshop, sponsored by the Mel and Phyllis Actor OHEL Institute for Training. My name is Arlene Ettengroff. I'm the director of the Institute. We're honored to welcome the professionals here with us today from all over the greater New York area, and thank you for joining us. For over 40 years, OHEL has been a strong presence in the New York area, providing housing, clinical services for families and children in need, and services for individuals with psychiatric and developmental disabilities. In addition, we also have offices in New Jersey and South Florida. Our agency is committed to providing innovative programs to meet the ongoing challenges facing our communities, and this workshop represents our commitment. Today's workshop is funded by the U.S. Department of Justice, Office of Juvenile Justice and Delinquency Prevention. We have a full schedule planned for today, and we'll be starting promptly after break, so please help us keep to our schedule. Please also understand that recording of this workshop is not permitted. We'll be taking a short mid-morning break. If you have a question for our morning presenter, please write it down as she's speaking. You have an index card in your folders. I'll be placing more on the tables in case somehow one is not in your folder. If you have a question, place it on the index card, and at the beginning of the break, bring it to me. I'll be here near the podium, and we will try to have the presenter answer as many as possible. You'll find also several readings in your folder on the right-hand side. There's also an assessment instrument that's going to be discussed in this morning's presentation, so I refer you to those now. Our presenter this morning is Dr. Irit Felsen. Dr. Felsen has achieved international recognition as a researcher, clinician, and lecturer. She has presented to professional and academic audiences throughout the world, including the U.S., Canada, Israel, and Europe. Specializing in the treatment of trauma and traumatic loss, including the transgenerational transmission of trauma, Dr. Felsen has served as research consultant to Yale University's Holocaust Trauma Project and has recently conducted research on trauma survivors at the Swiss Center for Neuroaffective Science at the University of Geneva in Switzerland. She serves on an emergency response team for the delivery of clinical services following critical incidents and provides on-site trauma intervention for employee assistance programs. Dr. Felsen has also served as clinical psychologist in inpatient adolescent psychiatry at Yale University Psychiatric Institute. She currently maintains a private psychotherapy practice in Mountain Lakes, New Jersey, with adolescents and adults, families, and couples. So we are particularly gratified that she's taken time from such a busy schedule to share her expertise with us today, and it's my honor to present to you Dr. Irit Felsen.
Thank you very much, Arlene. It's a real pleasure being here with you today, and I hope we'll have a good training. So let me start right away. As Arlene said, many years ago when I started my work as a clinician, I worked on an inpatient adolescent unit, and I was unmarried and very young and lived there for a good 90 or 100 hours a week, which I say always, after that, everything else is easy. Adolescents are, of course, not our easiest clients. So let us start by looking at a few statistical facts. What I want you to see is the prevalence and the impact of mental health issues in adolescents, because it is actually astonishing when you look at the numbers. Some of the numbers that I chose to bring to you are that 1 out of 10 adolescents in this country suffer from an impairing mental illness. Recent reports indicate that depression and depressive syndromes are very prevalent among adolescents, among children and adolescent youth. More than 25% of high school kids report dysthymia and hopelessness that are severe enough to seriously affect their social and academic functioning. 8 to 9% of youth attempt suicide. 5% of all high school youth use weight control strategies that would indicate a potential eating disorder. And nearly 27% of 8th graders increasing later to 54% of high school seniors report illicit substance use. 11% of high school students have a substance abuse problem. These are, I think, staggering numbers. And the mental health problems that we just spoke about lead to serious consequences, including impaired social, academic, and occupational functioning, increased risk for behavioral problems, and those include delinquency, promiscuity, family discordance and dysfunction, conflict with parents, accidental injury, and death. And when I say death, it always reminds me that in one of my very, very first shocking experience was that when I was at Yale, I was asked to do an intervention with a group of parents in Woodbridge, which is a very affluent, nice neighborhood not far from New Haven. And the intervention was with a group of parents, 10 families, all of whom lived in Woodbridge, not a huge city or town, just a small suburb, all of whom had an adolescent who died as a result of some kind of an accident involved with drugs, delinquent peers, and so forth. Despite these staggering numbers and the seriousness of the problems that go along with these numbers, fewer than 1 out of 5 youth in need of mental health services was shown to have received services and needed treatment by the survey of the NIMH. More important even than just that is the prevalence of individual problems is the fact that there is a co-occurrence in many problems. Things don't really come neatly one by one in life. All of us who work with adolescents know that usually they come as a raging package of different problems, emotional, behavioral, together, and the co-occurrence of, let me see, no, not here. The co-occurrence of the different problems seems to increase with age. So, for example, just to give you an idea of what I'm talking about, there was a big survey of over 10,000 youth that was done, and looking at problems such as a minor problem from safety issues and things like safety belt wearing in the car and taking care of things like that, all the way through weapon carrying, tobacco use, alcohol use, drug use, sexual behavior, and so forth. The results divided by age groups showed that most adolescents in this country between the ages of 12 and 17 did not engage in more than one health risk behavior, but the health risk behavior that were multiple increased with age. So only 1 in 12 adolescents in the age group, the early age group, 12 to 13, engaged in more than one such behavior. A third of the ones between 14 and 17 had more than 2 behaviors, and a half of those aged 18 to 21 had multiple behavioral and emotional problems. Male respondents had more multiple problems than females, and out-of-school kids in the ages of 14 to 17 were more likely to engage in multiple health risk behaviors. So what we see here is the need to intervene earlier before these problems become compounded. The leading cause of morbidity and mortality in these young ages, in youth, can be traced to several fairly small number of health risk behaviors that seem to start early at the end of childhood, even early childhood, sometimes, and adolescence. Many of them, as I said before, lead later to severe problems on social problems, family dysfunction, crime, school dropout, and then school dropout, as you see from the finding before, increases again the probability of multiple problems, because as we saw, the kids that were younger but were school dropouts had earlier onset of multiple problems and lost economic productivity. So the point of this little introduction as to the numbers and the impact of mental health and behavioral problems in adolescents is to say how important it is that we actually have the capacity to assess and to identify markers for problems as early as possible in order to introduce some preventive measures as early as possible. Because another thing that we also see in findings and research into these issues is that the children who start earlier will also offend and have problems longer time. It will be something that we need to intervene in as early as possible. I was going to show you a short excerpt from a show which in some ways I found good, the show In Treatment, which was shown here on TV. It's really based on an Israeli show, Betipul, where the psychiatrist is Asi Dayan, the son of Moshe Dayan, who's a very good therapist in the show and a well-known patient in various facilities and publicly speaks about it, and it's public knowledge, so I'm not saying anything that nobody else knows. I find the American version very different from the Israeli one, but nonetheless, it's a good sort of opportunity to see how we're portrayed and how therapy is portrayed to the public. And there is an episode there, or several episodes. One of the patients is an adolescent. His name is Jesse. And what I was going to show, which I will not show for reasons of good taste and so forth, is an episode where Jesse is very revved up and speaks to his therapist in a very rude, belligerent way, which all of us who have worked with adolescents know is no infrequent occurrence. So those of us with very sensitive ears have to choose a different population to work with. For example, I think I might have mentioned it in a different context, but I do remember one time, I was fairly young still, it was on the inpatient unit, and I remember a girl who went down on her knees. She was Catholic. She went down on her knees. She got into this praying position, which is very foreign to me, having come just, an Israeli, and it was very different. And she put her hands together, and she closed her eyes, and she started praying to God, please, please, God, save me from this awful woman. I wanted to mention to you the theory presented by somebody called Catalano as to the relationship between individual characteristics and antisocial development, because I think it's very important for us to look at the potential for delinquent behavior, as it seems so intricately related to emotional and behavioral problems in young children and adolescents. What he suggested was that while there are individual characteristics that are related to certain temperamental elements that he mentioned, some of which are, let's see, I think I put down here, some of which he mentioned were negative mood, a tendency for prolonged negative mood, quick fuse, a tendency to be easily angered, all of those things that we really know as part of the elements that characterize the kids that we see with conduct disorder and behavioral discontrol. He said his theory was that there are different pathways for the development of antisocial personality and prosocial personality, where the characteristics, the constitutional characteristics that have to do with temperament and the innate sort of greater or lesser difficulty in regulating arousal, physiological and emotional arousal, are mediated by three elements, or mainly the positive relationship, the development of a positive, strong bond with a caretaker or an attachment figure, which then means that that person's regard, that person's love, that person's expectations from the child become a very important element in the child's behavior. Or even for a child who has formed a positive bond with a caretaker, when for some environmental reasons the child begins to see that there is a great benefit in behaving antisocially and a small risk involved in it, then they might take the path of antisocial development, and which, by the way, I mean, if you think about it, immediately leads to the other things I'll be speaking a little bit more about, such as the role of parental control, monitoring, rules, structure, all of that. And third, when the bond with either a family member or other people in the close environment is a bond that is very strong and emotionally positive, but the person or that figure is an antisocial person that represents or presents an opportunity for modeling of antisocial behavior. Okay, so let's talk a little bit about childhood emotional and behavioral problems and adolescent delinquency, because I think that is often what brings children to treatment. Often they come to us not because they want to, but because they got into trouble, and someone makes them come to us. So various studies from every possible direction found an early, a strong connection between early emotional and behavioral difficulties in children and later delinquency and or drug abuse. It's a very strong finding. The predictors in terms of emotional and behavioral characteristics that show themselves early in childhood include conduct disorder, attention deficit hyperactivity disorder, major depression, and oppositional defiant disorder. It's okay, I don't need it right now, so it can be off. I don't know why, I didn't even touch it, believe me. Sorry? Okay. Early behavioral and emotional problems in children have been observed to persist from childhood to later development, so we shouldn't fool ourselves to think that a child who shows such tendencies will simply outgrow them. They tend not to. And that tends to develop at later stages to delinquency. And after that, very often, I think we talked a little bit about it also with regards to sexual perpetrators in the previous time I met with some of you, it later often develops into criminal behavior in the young adult. The presence of childhood emotional and behavioral problems, I want to repeat, is a robust empirical finding in terms of its relationship with later delinquency. So let's talk a little bit about family influence and delinquent behavior. What we really think is that, to sum it up, delinquency or antisocial development in children and youth results from an interruption in the basic caretaking, attachment relationship between the child and the parents. If I give you an example, rather than of one particular study, but of a study that did a meta-analysis of many, many studies that focus specifically on the role of families in juvenile delinquency, that would be the study by Lauber, 1986. I didn't include it in your thing, so I'm mentioning it. He found that lack of parental supervision, lack of parent-child involvement, and parental rejection or hostile parenting are very strong predictors of juvenile delinquency. Similarly, in another study that also looked at a bunch of other studies. The Yoshikawa, 1994, reviewed risk and protective factors in youth and revealed similar findings: hostile parenting, lack of supervision of parents lead to a direct effect. They have a direct effect on delinquency, and family structural variables such as the number of parents. Are there two parents? Is there only one parent? Are there multiple parents? Variables like that have an indirect impact on delinquency in later years. Inconsistent parenting, too permissive parenting, and weak attachment to the parents were seen in many studies as related to higher levels of delinquency and higher levels of substance abuse in children and adolescents. Also, lastly, violently offending youth that were involved in actually violent offenses, come from families that have less discipline, that are less cohesive, that have weaker parenting skills. And unfortunately, what we do know is that many of the kids that we see come from families that are characterized by weak parenting skills, less cohesion, and so forth. I was just reminded of a patient of mine that I saw a little while ago. Something else reminded me about her yesterday, whose parents were 16 years old when they met. They dated for 1 month, and the mother got pregnant. They got married, and the first 7 or 10 years of the marriage, the mother told her daughter that the father, although they stayed married and although he functioned as a breadwinner and so forth, which is a lot more than we see in other families, she said he was never there, he was always out with the guys, he didn't care how she felt. He was a kid, she was a kid, and they only knew each other for 1 month before they had this child. What kind of cohesion, what kind of family structure, what kind of parenting skills did they have? Indeed, by the way, their first child, which was not my parent, did exactly the same when she was 16 years old. So by the time the mother was 32 years old, she was a grandma. Okay, conversely, and that's the good side of things, conversely, in speaking with resilience, we see that positive family environments foster resilience. They foster resilience. We see it even in the face of early difficulties of all sorts: environmental, death of one of the parents, injury of one of the parents, injury to the kid, illness. Early positive attachments and continued positive, or what we consider pro-social families, families where there are rules, family where there is monitoring, families where there is continued positive attachment and involvement with in the child-parent relationship, foster resilience. So in other words, the family is a place where resiliency factors are cultivated. And in a longitudinal study, I just bring you a couple of examples to make it more real. Longitudinal study of about 1,000 youth by Oxford et al., actually 900 and something youth, but that's good enough. Even after controlling for the kind of socio-cultural environment, the kind of peers that the kids had around them, and so forth, pro-social families, the kids coming from these pro-social families, as I characterized them a minute ago, have been seen to have resilience to early onset substance abuse and delinquency. So even in unfavorable environmental conditions. Bourne and his colleagues, as well as Bender and Lozel and his colleagues, both studies from 1997 found that youth with higher social support, defined modestly as having someone to help with homework and someone to talk to, were much more resilient to substance abuse and delinquency, despite the presence of many other risk factors in their environment. I want you to also notice this this study I thought was just amazing, so I brought the whole abstract here to read to you if you would like. The effect of having dinner with the family. Just having dinner. So listen to this. Okay, constant positive associations were found between the frequency of family dinners and all developmental assets, including both external and internal assets. Speaking of internal and external assets, I did include in your handouts a table of those which we'll speak briefly about in a minute. But before you go there, let me just finish reading the results of this study, which I think are amazing. Consistent inverse relationships were found between the frequency of family dinners and all high-risk behaviors measured, i.e., substance abuse, sexual activity, depression, suicide, antisocial behaviors, violence, school problems, binge eating or purging, and excessive weight loss. The frequency of family dinner is therefore an external developmental asset or protective factor that may curtail high-risk behaviors among youth. Family dinner. That's all. We're not talking about changing profound attachment paradigms in the parents, which is very, very complicated, as you well know. And we do know that parents who have issues in their attachment paradigm, it's been shown by a huge number of studies using, starting with Main and her group. Mary Main looked at attachment styles of parents and how they affect the attachment style of their children. I think one of the most baffling findings, if you like, from that group, just to remember, if you remember one, is that when parents' own attachment style paradigm was measured, the way they come as adults, and then the attachment style of their child was measured before, when parents were not pregnant yet, their attachment style was measured. And predictions were made as to what attachment style their child not yet born will have. These predictions were, unfortunately, validated. So without some amazing degree of self-reflection, which we can talk a little bit more about because one can get very pessimistic looking at this data and say, well, if that's the case, then what at all are we here all doing? Should we move to a different profession? So we can talk a little bit about that, but without a huge degree of self-reflection, whether through therapy or through some other opportunities that life sometimes fortunately brings about, without that, one is doomed to continue the same unfortunate patterns and expose one's child to the same unfortunate pitfalls. I would like you to look at the developmental asset charts, if you don't mind, that I included in your handouts. We won't go over it very, very carefully, but just a little bit to say that as part of the optimistic fairy dust that one does have to sprinkle sometimes, we do need to look at some of these things and see how sometimes small things can matter, external and internal. Just a bissel of luck, as you know, I said last week in a different talk, a bissel of luck goes a long way sometimes. So look at it. Family support. Of course, family life provides high levels of love and support. That's a wonderful thing and a huge factor in individual resilience. Positive family communications. All of these things we would like to have, we would like to increase, but they require a lot of work. Look at other things. Number 3, other adult relationships. If the young person receives support from 3 or more non-parent adults, and the support can be not much. This is the amazing thing. You talk sometimes to adults who come from incredibly difficult circumstances, and you hear about that one neighbor that was really kind, that one teacher who seemed to like them and get them and believe in them, the one art class instructor, somebody, and that might sometimes be enough. Caring neighbors, caring school climate, adults in the community value youth in ways that are expressed by, creating roles for youth to do something positive in the environment, in their community, service to others, 1 hour or more, but 1 hour per week can provide such opportunities to experience oneself as a valuable, pro-social member of society. Look down at these things and see how certain things that we can think of as very minor, such as a program of 1 hour of some sort of an activity in school, after school, how these things can have an enormous effect, and how important it is to, in any possible way, as not as individual therapists, but also as individual therapists, to encourage children and families to participate in such things, and to encourage communities to develop even small resources like that are community-based, because they have a tremendous impact. Okay, let us go a little bit into the issue of engaging adolescents in therapy, which is really an art in and of itself. I think some people have that gift and some people have less of that gift. It's in any case always not a trivial hoop to jump through. In contrast with the fairly large literature that exists by now about what are elements that promote therapy process with adults, with children, and with families, we have actually pretty little empirical knowledge about what are the factors that promote adolescents' engagement in therapy. Now, this is an incredibly important issue because adolescents are very different from children and very different from adults. They are in no way bigger children, even though sometimes parents tell them that when they are upset with them, and they're in no way younger adults. Young adults is something else. Adolescents are a different species. And adolescents come with a lot of issues that I'm sure we are all aware of, and I did not want to really spend too much time about really general ideas of adolescent development, which I'm sure we're all aware of. I would like to refer you to the classic paper by Peter Bloss from 1967, the second separation individuation process during adolescence. That's how it's called. And it's a little bit difficult to find on the electronic journals because it's a little bit older, but it is a classic that describes very well the processes of adolescence, the complicated negotiation between a need for growing autonomy and the weakness, the relative weakness that is actually created by all of the physiological changes, the hormonal changes, the, on one hand, sort of distancing from the parents as sort of an alter ego, because we need more autonomy, we need to be more by ourselves, but at the same time experiencing internally a weaker self because of the surge of all of these, hormones and physiological changes, and the need to connect with peers, different peers, that comes to supplement that weaker ego that's trying to get away from the parents and trying to figure out how to deal with all of these drives, and therefore the unusual intensity of these attachments to peers, which is both an opportunity and a good thing, a growth opportunity for adolescents, and also a great liability depending on what peers they attach themselves to. I do want to mention here, I don't know if that is exactly where I meant to mention it, but as I'm speaking of this, I will mention it here, that another very robust finding in the literature, empirical literature, is that connecting with antisocial peers, delinquent peers, antisocial peers, is a very strong predictor of delinquent behavior and substance abuse. And the explanation for that is interactive. It says children or youth seek to connect with those that share similar tendencies, but having connected with them increases the individual likelihood of a kid to behave antisocially and to up their antisocial behavior by the influence of the delinquent group or the antisocial group that they became part of. So, as I said, I will not, unless somebody really wants to and has some very burning question about adolescence development in general, I will not spend too much time on it, just a little bit in direct relevance to the engagement of adolescent patients in therapy. Like I said before, like Peter Bloss said when he called the article the second separation individuation, he obviously was making a reference to Mahler's concept of the first separation individuation of infancy, which speaks about the child attaining the sense of autonomy and that phase in which a small child around 18 months to 2 years is sort of approaching the mother and getting away from her, sort of that kind of a baby, that image of a toddler, which we all, I'm sure, still have in our minds, coming to you, and as you're taking them, they're going this and they're going away. They just needed to come to do what she called emotional refueling. They needed to see that you're there, they needed to see that you're available, but for that, they came, got their refueling, they came for that, and with that they go off to explore what else is around. That's the separation individuation of childhood, which has to do with the two concepts, the two aspects. The physical separation, greater distance, greater exploring of the world, and individuation, which is the internal greater distance and a sense of selfhood that is coming to be. So second only to infancy, adolescent is a phase that entails the most rapid and drastic changes in development, including physiological, cognitive, emotional, and social transformations. What we also need to remember very, very much when we see adolescents is something one might not be so sensitive to always, but please remember two things. One, there are huge differences in the maturational pace between individuals. So when you see someone who's 14 or 17, bear in mind that it's very, very important to assess specifically where this person is and not make assumptions about where they are with regards to their physiological, psychological, emotional, cognitive development, because some of the children, especially some of the adolescents that we will see that have compromised environments and compromised emotional circumstances that they come from, will have very delayed areas of development, whether emotional, cognitive, and sometimes even physiological. There are also, and that is as important to remember, there are also great differences within the individual in the rate of development of different aspects. Someone can be very advanced, like a gifted child, can be very advanced intellectually and very immature emotionally. That's one example we are all, I think, familiar with. The other example is the child who has emotional issues or abuse history, who can be very advanced cognitively and emotionally in speaking about things that do not pertain to them, and then be extremely not developed or in a different place developmentally, both in terms of cognitive ability to think about things, to think about the other person's perspective, to think about the impact of their behaviors on the other, the effect of their behavior on future consequences when it comes to emotionally arousing personal information. We have to remember that. So with regards to the relevance to engaging in therapy, I think we need to look at the different factors in our assessment. We need to look at these different factors very carefully and understand. For example, physiological development. Look at the child, get from them a sense of where they are, because even simple things like when and where did they enter puberty can have a huge impact. For example, my cousin, who is a very tall, strong man today, he entered puberty very, very late. He spent the most part of his adolescence as this tiny, wispy little kid. Or this other guy in my class, who is now the head of obstetrics in one of Israel's hospitals, he was this tiny little kid with long eyelashes on which he used to hang rubber bands during classes, and looked like a little girl most of his adolescence. This is how I remembered him when we went into the army. And I can tell you, I'm sure his experiences in the army were not fun, having been this way. But when I met him 15 years later, he was a regular guy, not huge, but a regular-looking man. So for a guy entering puberty or achieving, physiological maturity relatively late can be very different than achieving physiological maturity early. Those who achieve it earlier actually experience a boost in self-esteem. Guys, that is. On the other hand, for girls, achieving physiological maturity early can be very complicated and involve all kinds of problems that lead to depressive experiences, feelings of shame, feelings of discomfort with their bodies, eating disorders because they want to still be skinny and slim and flat like everybody else when they're becoming much more voluptuous, is the word, and so forth. And a host of issues that go along with that. So physiological development has to be looked at carefully. Cognitive considerations should be considered as well. Like I mentioned before, troubled adolescents may be, and most likely are, less cognitively and socially mature than their regularly, optimally developing peers. And we also need to be very aware, like I said, of uneven levels of development in their cognitive abilities. What we also need to remember that with regards to therapy, therapy can be a very uncomfortable place cognitively as well as emotionally for adolescents. They can feel very much at a disadvantage, especially if they are cognitively and emotionally both a little bit behind their age and they're having a hard time putting together feelings and thoughts and the other's perspective and their impact on the other and all of those mental symbolizing processes and operations that have to do with a higher level capacity for mentalization, what we call. And then we get them into the room and we say to this troubled kid with conduct disorder, with impulsivity, with difficulty mentalizing internal emotional processes, we say, so tell me, what's bothering you? All right? If they could use that level of mentalization to begin with, they wouldn't have a conduct disorder, right? So the setting itself is a setup for failure in many, many ways, and we have to recognize it when we come to treat this, this kind of an adolescent, which is why, for example, at YPI, where I was, we played basketball, we played cards, we played games, we went for a walk if the level of safety that the kid has achieved allowed. At the time, we all smoked. We were young. We smoked with them on the courtyard. We did all kinds of things that were just a way of being together that, if not in itself yet allowing us to address issues, was at least a way to establish a sense of comfort together so that we didn't start by putting them at a disadvantage. Yeah? In fact, it was perfectly fine if they were better at basketball than the therapist or better at the card game than the therapist, because we have to understand they're already in a pretty bad place, and we're asking them to help us help them in the language that we're comfortable in and not they. Okay. I would like to highlight a couple of specific cognitions that may be of help or not of help in therapy and need to be, I think, specifically addressed. One is delinquent cognitions. Kids who have already sort of fallen into the antisocial sort of path, as we called it before, pathway, have a way of rationalizing their behaviors, and that is one thing that we have to be very careful about. We have to be very respectful of what is happening with them. We can't push them. We can't say, you're lying. We can't say, we can't address it head on this way, but I think it's very important that we communicate at the same time that we do not support that rationalization, that this is something we maybe will continue to talk about, that we perhaps see it differently, that we understand that this is how they present it right now, but we hope maybe they're going to be able to see it in some different ways in the future. We don't address it head on and get into a confrontation, but we have to also make sure all along that we do not collude in any way or are perceived as colluding and as condoning that rationalization. The other thing is, I think we do need to understand that the attachment, that's slightly different. It's not so much about the cognitions, but it's related in some way. The attachment history that the child comes with, and I'm sure we'll talk a little bit more about it in a minute, will also mean that some kids with an anxious, insecure attachment will try to overcome their anxiety in engaging in therapy as soon as possible, because that's the way that they overcome that anxious place that they feel they're put in. While that will be, of course, conducive to therapy. That will be an attitude, an approach, an emotional, cognitive stance that will be helpful, although there too, one has to be aware of the nature of it and the fact that it is, in a way, the kid is thrust into a pseudo attachment too fast because they're so anxious, and not to think to ourselves that, this kid attached really easily. This means that they have no attachment issues and they're engaged in therapy and everything is fantastic. No, in fact, what you can see is what I just said, a pseudo attachment fueled by intense anxiety and anxious attachment, which means they might try to do whatever they think you want them to do, just like they learned at home, and that is not necessarily what you want to foster in their therapeutic engagement and alliance with you. In other cases, since most of the adolescents that we see will be ones that come with attachment histories that are far from optimal, in other cases, we will see the ones that cope with attachment anxiety by defending themselves from taking any risk, from getting involved with anybody again, getting disappointed, getting hurt, and some of their behaviors can be very off-putting, very difficult. And in that way, I would like to maybe weave right into here something about what we know from therapy process studies with regards to adults. One of the most important predictors of outcome in therapy is the therapeutic alliance, that bond which comes to be between a patient and a therapist, the sense of being understood, of an emotional involvement. Now, one of the things that were seen as very important in establishing that alliance is actually, said to say, first impressions. First impressions. And I'm saying first impressions. I'm not talking the first 6 months of therapy. I'm talking the first session. This is what you get. And that means that when an adolescent comes and they're putting their entire armamentum of off-putting behaviors to make sure that they don't engage with you and you don't think they're going to engage with you and they don't care about you and they're giving you their most belligerent or most detached, most unpleasant self, what can happen is that occasionally we are also human and we are put off by it. We're put off by it, and our sense of being put off and not liking this patient or thinking that there's not much chance here, our own pessimism gets into the space in between and affects the kind of first impression that they will get. They will then not be likely to get the impression that we're very present, that we're very warm, that we're very respectful, that we're very open and welcoming to them, and that will be not a good predictor of therapeutic outcome. And let's face it, this is what adolescents are good at. Normatively developing adolescents, at best, are not often the most engaging and charming people for adults. Many adults are intimidated by adolescents that are normatively developing, not to mention those adolescents that come to us because they were made to come to us, they were mandated to come to us. They don't really necessarily see any reason why they should come to us. They don't have any faith. If they see a reason, they don't have any faith that we can change anything for the better for them. And they're threatened and are put in a situation where they feel at a disadvantage. Right? Okay. Another thing that I would like to point with regards to the socio-ecological sort of meaning of putting an adolescent in a therapeutic setting is that there are two very big mismatches there for the adolescent, between the adolescent and their developmental capacities and the demand characteristics of therapy and the therapeutic settings. One is, like I mentioned, they have no choice. They have no choice. Many of them have no choice when they come to therapy. Either in the good case scenario, they were forced to come there by their parents, and in the bad case scenario, they were mandated to come there by the authorities. And an adolescent really is engaged, developmentally speaking, in exactly the opposite, in being independent, establishing their autonomy, and so forth. So there's an inherent mismatch there developmentally, and add to that that we said before, adolescents are exquisitely sensitive to peer relations and peer status and peer views of them, and going to therapy is stigmatizing. Being someone who is, crazy, being someone who is, whose family is crazy, all of these things are a stigma, and they are very reluctant to take that stigma upon themselves. They much prefer to be delinquent than acknowledge mental health issues. Delinquent is cool. Mental health issues is not. Being mental is not. So we have to be aware of that, and we have to address these attitudinal, cognitive issues right from the beginning. We also have to be aware of the fact that what we may consider helpful and welcoming, such as questions about, so what's going on with you, so tell me, so what happened, can be experienced, again, by an adolescent who's very much trying to be autonomous and private and so forth, as very intrusive and probing. So those are some things that I think have relevance to the engagement of adolescents in therapy, and things that we have to keep in mind when we're trying to do that. However, what we see is that therapy with adolescents is actually very helpful oftentimes. I will say that already here. And what I'm hoping is that in the latter part of my time with you, how do we do time-wise, Arlene? Where is she? Left? Okay. 10:30. And we are stopping at 12:15. Okay, hopefully. What I would like to do, and I would like to ask you if that's okay with you, I brought the actual full evaluation of an adolescent to go over with you and show you what I think would be kind of the optimal way for us to evaluate an adolescent. Now, granted, life is far from optimal and is getting further and further away from it in the mental health arena, but it's still some kind of a standard to work towards. So would you like to do that? Okay. So let me try to do this somewhat chop. So let's talk about the involvement of parents and adolescents. We talked a little bit about how difficult it is to engage adolescents in therapy, and we can talk a little bit more about it then later as to, okay, so what do we do? And I will say that literature does show that involving the parents and the adolescents in their treatment is very effective. Both in the case of children and in the case of adolescents, it's really hard to effect real changes without involving the parents, given that the parents are still such important players in the adolescent's life, this way or that way, whether they do what they need to do and whether they don't do what they need to do, the impact is very important. Yeah? So we would have to admit that our profession was not very kind to parents of children with mental health issues per se. This has changed over the past 25 years or so, but it has taken about 2 decades because initially the stance of our profession was, as was put by some parents at some point, it was a blame and shame. We blamed them and they felt shame for the fact that they somehow produced a child with mental health issues, obviously because of some shortcoming in their parenting skills. Parents were viewed really for a very long time as more part of the cause of their children's issues rather than part of the solution to it or participants in seeking for a solution. And that's a very complicated issue which in the end, when we end our review of the findings and all of that, we come back to it and we can talk about it, because findings do show, like I said before, that parents' lack of rules and controls and lack of monitoring and poor, weak attachment to their child and all of that is indeed a very strong predictor of mental health and behavioral problems and risk behaviors in children and adolescents. So what are we saying? Well, we are saying, even if I say it prematurely here, we are saying that every case has to be looked at, and that, as I mentioned before, there are certainly constitutional elements that we come into this world with, vulnerabilities, constitutional vulnerabilities, genetic vulnerabilities, and environment plays a critical role in mediating it, would be the way that the language we used in the past for it. And these days, we're really coming to a very important new way of looking at it with the study of epigenetics, that is really the study of how the environment and lived experience trigger those physiological genetic elements that we come into the world with, really triggers the expression of genes that otherwise might have not been triggered. And at least at this point, some fairly complex behaviors that have to do with rearing the young and have to do with protection of the young and all kinds of fairly complicated behaviors like that in lower level animals have been seen. So you can trigger genes that are involved in fairly complex behaviors or not trigger them. And that has something to do with this whole issue. But back to the original way our profession looked at it, I still had the honor to meet personally Ted Lids and Stephen Fleck, some of the giants, psychiatrists of Yale University at the time, in the 50s and the 60s, who coined the unfortunate term the schizophrenogenic mother. At the time, and based on some very interesting research, not exactly sort of taken from thin air, they claimed that many schizophrenic adolescents have parents who utilize complicated double-bind type of communication that confuses the child and makes it impossible for the child to know what is actually wanted from them, what is expected, and leads to the development of mental health issues, even schizophrenia. Similarly, in the literature about autism, there was a lot about the mother who produces an autistic child because she's cold and aloof and doesn't provide good enough attachment. So those are just a few examples of what the stance of our profession was historically. And this has changed to now viewing parents as collaborators in their children's treatment, and often even in programmatic and higher level sort of political change that has to do with provision of services. Behaviorism, for example, which in this country took hold very well in the 60s, radical behaviorism that said that really what matters most is the environment, had definitely part in the profession's view that, parents shape their children to be what they are. And as I said before, to some extent, and with many constraints on that statement, we are coming to a different recognition that it's both true and not true. However, like I said, involving parents in the treatment of adolescents as well as children is very, very important. I do want us to keep in mind it's not a simple matter. There are several things that I'm sure jump to your mind as we talk about it and why it should be so complicated. First of all, they come because they already have gotten into a lot of trouble, which means their parents are upset, their parents are at the end of their wits, their parents are angry, they have a very conflictual relationship, they have very conflictual attitudes, all of that, they have conflicting values, they are in very different and opposing adversarial place, and we are supposed to work with somehow the kid and the parents. Because I'll tell you another thing. The literature about therapy process in family work shows that the best outcome is associated with the capacity of the therapist to develop what's called, it's not really the word, I'm blocking on the word, but the concept is concomitant empathy. Like an empathy that is at the same time there and felt by all participants. Now you tell me how easy it is in a situation like that to be equally and simultaneous empathy, right? Simultaneously empathic, and not only simultaneously empathic as you feel inside, which is half the trouble. You can feel sometimes very easily simultaneously empathic to both the difficulties of the adolescent and the parent. But to have them experience it this way is the other part of the trouble, because they are so, their sensitivity is so heightened at that point, and it's so easy for them to see you as siding with the other at any moment. So that's one difficulty. The other difficulty is, of course, the issue of confidentiality, because adolescents are in this very sensitive place. They're trying to establish their own identity and so forth. If they are to engage with you, if they are to tell you things that they didn't want to tell their parents, they don't necessarily want you to tell their parents, right? And sometimes they do want you to tell their parents. Sometimes they do use you as a way to actually tell their parents things that they could not tell them. But even when they do, they'll never admit it. So you have to know that that's what they want you to do, but save face. You have to help them save face and not make it seem like they want you to do it. It has to be a different way. It has to be that you manage to do it without saying, he wants you to know that he's really sad. He wants you to know that he's not really so angry. What he really is sad. Or what he's not pushing you off. What he really is he wants more of you, but he's so disappointed and thinks there's no way he can get more of you. You cannot say, he wanted me to tell you. It has to be a different way. So what I want to do now is show you a few of the ways in which we work with parents and how important it is that we order in our own mind before we see the child and the parents, or after seeing them. We as the therapist have to be clear in our own mind what kind of an intervention are we doing here with the parents and the adolescent. Because there's all these people in the room, there's all these different issues. We have to decide who's the patient, right? Who's the patient? So let me try and show you. My daughter, the adolescent, helped me and created these things for me. Just 1 second. Where are we? Escape, she said. And, no. We want to go here. Okay. So what I asked my daughter to do is to do these things, which I drew for her, as ways for us to look at some of the models that we actually employ in working with adolescents and parents. So here is the classic one. This is a child in individual therapy. Oh, look at that. Child in the center. I'm very excited about my budding technological competencies. This is a child in the center, is in individual therapy. The therapist is here, and father and mother are on the periphery. They are involved occasionally, of course, in the first session. I always, I don't even need to say it, right? There is like no way you meet with an adolescent or a child without their parents for the first session. And if they cannot sit together, that's fine. Then you meet with the parents and you meet with the child. But very close together in time so that it's very clear that it's essentially, that's the starting point. You get their view, you get their view right from the beginning. That's the starting point, okay? So the therapist is there, the child is the identified patient, the child is the individual patient, and we meet with the mother and the father after that first session where we essentially take the history and the viewpoints of everybody. We meet with them occasionally to inform them, to find out from them things, to help them with some ongoing issues and so forth. But that's the usual model. We're all familiar with it, right? Right. This is parental guidance. We meet, the child or the children are in the focus of treatment still. They are the focus of treatment, but we are meeting with the mother and the father either with the child or sometimes with the child not present. They come to us because they need guidance. There's an issue and they want some guidance from a professional. They want to know, they want to learn about some developmental stuff. They don't know, is this appropriate, is this not? How do you deal with this? They want to learn about parenting skills. The issues are fairly limited. The issues are fairly clear and child-focused, like I said. And the setting can be either one parent or both parents or with the child, with the hope that whatever other processes occur in each parent will be, triggered perhaps by our discussion, but issues about the parent's own childhood, their own emotional stuff, are not part of this. This is really more a psychoeducational type of intervention. Yes? Okay. Then, the parent-child relationship therapy are all kinds of variations, really, that are similar to family therapy. They are interventions between problematic dyadic couples in the family where there's a problem. Either the problem is between one parent and a child, or the problem is between the parents and the child, or one parent with the child and then the other parent is present as well. But really it's saying, let's say my family Schwartz, where the mother had a terrible, terrible problem with the son. The son was a Boy Scout. He was a great student. He was great at church. No, this was not Schwartz. It was a non-Jewish family. He was great in church. He was great in the Boy Scouts. He was great at school. There were no problems. He had good friends. Everything was fine. At home, the relationship with mother was a monstrosity. She couldn't say a word without him flying at her. He couldn't breathe without her flying at him. It was intolerable. It wasn't like that with father. Father was much more tolerant of him, much more appreciative, did not feel that he was, compromising his authority all the time. It was really between the boy and the mother, but I definitely had to do a lot of work here between mother and father about how they each saw the child, because the things were so difficult between mother and the boy that she felt very threatened by the fact that the father did not experience it like that. And why doesn't he experience it like that? What does it mean about her? What does it mean about him? Why doesn't he support her? Should he support her? And he was like, should I support her? I mean, I don't, it's like, so that's another model Okay? This model is the messy model. This is the family system theory. This is what you like. Good for you. This is, you know, everything is for grabs. This is everybody as much as possible in the room. You know, some people really think that it should be the entire family for every session. Some people are a little bit less demanding than that and will take whoever can come to the session. And here, really, the family is seen as the psychological unit and the client. And the family behaviors are looked at from that perspective as serving the purposes, sometimes the defensive purposes, of the family as a unit. And so things have to be looked at in that way. How does it serve the total framework, each behavior? And even if the child here is the identified patient,